I want to answer this question about how to move on after experiencing a miscarriage. It is so normal to feel lost, and please know that you're not alone. I'm so sorry that you're going through this. A miscarriage at any stage of pregnancy can feel so absolutely devastating, especially after all of the time, the effort, the hope, the emotional energy that gets invested. I want to start off by saying this is not your fault. And this is extremely common because of the typos and errors that can appear in the embryos, often coming from the egg. This is a normal part of our biology. But even in the setting of PGT with IVF, where we think that the embryo is genetically normal, miscarriages can still happen, and there's a variety of causes. So let's talk about how to manage and move forward. The first step when you're diagnosed with a miscarriage, and let's use the example of the question that was being asked here after a frozen embryo transfer with IVF. The first step is, once this has been diagnosed, we have to figure out how to manage the miscarriage. And there's really three options. One is expectant management, where we just kind of wait for it to pass on its own. I generally don't love this option. I usually don't recommend it to my patients because they can often feel like they're stuck in limbo. But it is fair to stop the medications and see if there's an onset of bleeding and cramping. I tend to be more proactive and offer one of two approaches, either using medication to bring on cramping and bleeding. This tends to work better earlier in pregnancy, so before 9 to 10 weeks. Beyond that point, I would recommend a D&C, but there are also other differences to consider. Using the medication can help you avoid the anesthesia required for a D&C, and in some cases it could be simpler. But for those patients that are really worried about the bleeding and the cramping and going through that experience, a D&C may be emotionally and physically easier. Additionally, there is some evidence that a D&C can hasten the time to recovery and maybe speed up how long it takes for the HCG pregnancy hormone level to get back to baseline. Another potential advantage of a D&C is that you can collect tissue in an attempt to send it off for testing and understand if there are any identifiable genetic causes. I often will do this if someone has a euploid embryo transferred and then a loss, because there can be a limited resolution of PGT in a situation where you might have missing or extra DNA, micro duplications or deletions that you can pick up using a specialized technology on the tissue that is sent for testing from a D&C called microarray. But a D&C requires anesthesia, it is invasive. There is a small risk of scarring after a D&C, especially in patients who've had repeated D&Cs. But I do think overall it is safe and it can be done gently. After the miscarriage is treated or resolved, then I like to track HCG levels. And this doesn't have to be often, but I like to check in maybe every 2 weeks just to make sure that the levels are dropping. And if the levels start to plateau or the decrease starts to slow down, we'll do imaging in the form of a saline sonogram to rule out retained fetal tissue. And that may require intervention. Once the HCG levels are negative, then I'll consider if there's any need for additional testing. For example, if this was your second consecutive miscarriage, I will typically do a recurrent pregnancy loss workup where I will do karyotypes for both you and your partner. And I want to look for any sort of predisposition to having a higher than expected rate of errors, genetic errors in the embryos versus what we would expect for your age. I would test for things like antiphospholipid syndrome. So these are markers in the blood work, autoimmune markers that can predispose you to blood clots, and you can mitigate the risk of future miscarriage by putting someone on blood thinners. I'd also consider DNA fragmentation testing in the sperm, thyroid, autoantibody testing, and looking at TSH levels, and doing some form of uterine cavity imaging. This could be a hysteroscopy, a saline sonogram, or an HSG, especially if there's a history of endometriosis, infections, pelvic or abdominal surgeries. I want to look for possible tubal disease that could also be a culprit in causing miscarriage. Once the imaging is clear, and once you feel emotionally and physically ready, you can try again. And there's really no reason that you have to wait for an extended period of time for months unless you feel like you need the time to heal and to take time for your mental health. I think something that doesn't get talked about enough is the emotional fallout. Having a prior miscarriage can almost feel like a form of PTSD. The anxiety that people feel leading into their next cycle can be really intense, and often that fear isn't going to subside or get much better until you're past the gestational age where that loss occurred in the prior pregnancy. And sometimes you're not going to feel better until you're in the second trimester or until the delivery. And this is completely normal, and it's so important to be prepared for it. Find a therapist, join a support group, whether it's virtual or in person. Talk to your friends and family members. There is no shame in what you're going through, and it's not your fault. I have had patients in this situation deal with anxiety and grief and depression after experiencing a loss, and they felt a lot better after starting certain medications to bolster their mental health. Do whatever you need to do to support yourself. Healing can take time, and that's okay, and it is possible. And when you're ready, we're here to help you try again.